Welcome to the orthoPAC podcast with your hosts Sam Dyer, Chuck Dowell, and Miles Gilbreth. Please join us as we attempt to fill in the gaps between education, current events, and real-world practice. Good morning, listeners. Today I'm pleased to announce our next guest. A PA, works in primary care, and is the current president of the Society of PAs in Family Medicine. Jim, welcome to the podcast.
Well, thank you so much, Sam.
Really excited to have you today. Why don't we jump in and tell us about the SPAFM and what's going on with it and where it's going and that kind of stuff.
Sure. So the society was actually much more vibrant a number of years ago, and for a variety of reasons, many of which I'm not sure exactly why, it kind of became dormant. And so I was at a meeting in at the conference, and I was asked if I'd be interested in being in a leadership position. And so I said, absolutely, and primary care is my passion. And so through a series of votes with the board members, I became the president of the society. I'm a serial entrepreneur, which you'll see as we talk later. And so I'm treating this like a startup. And fortunately, and I've been in a position as the president as opposed to president-elect about 8 months. And we've already made some real strides in terms of increasing membership and awareness, focusing on people, one, understanding primary care and what it does, but two, getting people more interested in primary care as a professional choice. So that's sort of where we are to today.
Jim had written an article about basically his personal experiences with primary care, and the title of the article, which was published in November of 24 on the AAPA news feeds, called The Interconnected Journey of a PA from Rejection to Innovation in Primary Care. And it's a very interesting read. I run into a lot of PAs who are interested in doing their own gig, kind of opening their own shop, so to speak. 2007, you opened a PA-run clinic in an underserved Hispanic community and did quite a bit of work with Medicaid. So can you tell us a little bit about that?
So I graduated PA school in 2003. I was really fortunate that I did 5 of my rotations at Mayo Clinic in Scottsdale, and fortunate in the sense that it was an excellent training place. They didn't have a lot of exposure to PAs at the time, but they did have residents and they did have medical students. So they basically treated me like a medical student or resident. Whatever they did, I had to do, which was at the time difficult, but I was really pleased to do that. In 2007, I found out a physician basically was going to just shut his doors. He was going out of business, didn't care anymore, was kind of just burned out on medicine. And so I heard about it and I went to his clinic and asked if he'd be willing to sell it. And he said, sure, but can you run a clinic? So I went to the board and I looked up the statutes and I checked with my accountants and attorneys. And lo and behold, because it was in an underserved area, I was able to own and operate the practice without a physician under roof. Had to have somebody signing our notes and kind of be available telephonically if we had a problem that we couldn't deal with. But we were we were an APP clinic. We had 4 PAs and 4 nurse practitioners by the time we got to the end of it. And so, started out with myself, and I fired all the staff, and I went in and I like put the business back together. I took it apart, put it back together like an MBA would. And I did all of the work. I checked people in, I weighed them, brought them back to the room, did the evaluation, checked them out, and I sent out the billing. So I really learned the system from the ground up. The Latino underserved community, they have to trust you, like anybody anywhere. I mean, I think that's common in any community, and they typically don't go for prevention. They go when they're sick to see somebody. Normally, the hospital, go to the ER. So they were filling the ERs, and we were trying to convince them through programs at the schools nearby and other programs we did, health fairs and things, that, come to us first so that we can keep you from going into the ER and waiting 5 hours. And it worked. They started, buying into that kind of mentality. So we started to grow, and then in 2008, 9, the crash hit, and Medicaid in Arizona we call it Access, uh, and Access is managed by health plans. So the two big ones are Mercy Care and United Healthcare Community. And so we were getting busier. I had two providers to feed, and when I say feed, payroll and all the other things that go with that, and a staff. We had MAs and we had check-in people and others, and so I was kind of in a position of having to fund it myself for a while because we were almost exclusively Medicaid or cash, and both of those things dried up during that 2008, 2009 period. So I went to a dinner, and I was invited to a dinner with the Hispanic Chamber of Commerce in Phoenix, and I met a fellow named Tomas Leon, and he was the CEO of a group of clinics for SMI, so severe mentally ill. And severe mentally ill, that's not a diagnosis. It's a designation, which means if you were able to get disability through Medicare because of your mental illness, you became severe mentally ill. And they were able to keep their Medicaid and also got reimbursed through Medicare for their insurance needs as well. And most of them are on disability, so that's how they had monies. Now we're in a low socioeconomic community, and so it fit their needs pretty well. So he said, "Hey, I've got all these, they're homeless folks, and some are semi-transient in and out of living conditions. Some live with people, some may even have families, but they're in the hospital constantly. Is there anything you can do?" So long story short, it took us almost a year to work a program where they would make sure that they were controlled on their behavioral health medications, and then they would come in to see us, and we would control their diabetes and hypertension and COPD, even drug abuse. We were able to help with some of that. So their normal kind of disease states. We see a lot of abscesses and just a lot of diabetics that needed a foot. Amputated. It was kind of across the board. We saw everything. So Mercy Care. Now I knew the Mercy Care and United folks, the leadership from my days in the hospital. So a gal named Christy heard what I was doing, came into the clinic and said, "Hey, would you be interested in doing it with our SMIs?" And I said, "Sure." I just opened my second location, and we didn't have a lot of patients at this time, so I'm like, "Sure." So we took they gave us 150 patients, and then United came in. And I knew the medical director from back in the day, and he knew what Mercy Care was doing. Now these are the two largest, so they're fiercely competitive. And so for them to trust me enough not to share their information with their competitor, that was a real, I felt it was a real kind of compliment that they knew that I would be trustworthy. And I didn't share the information. So we took their 150 and we took Mercy Care's 150. And it turned out they wanted to bid on the upcoming REBA, Regional Behavioral Health Authorities bid for the SMI population. And it was a $5 billion with a B contract. So we went through this for about 10 months, about 4 months before the actual contract was going to be up for bidding. And after 10 months, we showed that we reduced ER and inpatient visits by 79%. And we were all stunned at the number. We knew we were making a difference, but we had no idea that we were making that much of a difference. So Mercy Care and United bid on the REBA. Turns out Mercy Care got the contract. They joint ventured with our county system, which is county hospitals, kind of like Parkland in Texas. And so Mercy Maricopa was born, and both United and Mercy Care were really impressed with what we were doing, and they asked if we wanted to transition from fee for service to patient-centered medical home with only Medicaid patients. And so that's sort of how we got to the point where we made the transition from fee for service to the patient-centered medical home.
Gotcha. So I have a few questions from that. How did you make money seeing Medicaid patients? That's the first question. And then the second question is, did that panel of 300 patients grow once that contract was completed, or what happened then?
So we made money because remember we only had APPs, PAs and nurse practitioners. So our cost of doing business. Now remember, I'm an MBA, so I'm thinking about it from that perspective. The cost of doing business because the salaries, the benefits, malpractice, et cetera, was substantially back then less than it would have been for a physician, like half. So our cost of doing business was low. So having lower reimbursement from Medicaid really wasn't as big an issue as it would be, say, from a physician practice standpoint. And so to answer your second question, it did grow, and it grew to be actually fairly large, and but not just the SMI population. It was the populations from Mercy Care and United grew because we became sort of the favored practice, small practice. Seven's considered small to them, small practice in the locations we were in. And it's all geographical. You can't take patients from 10 miles away. They've got to be relatively close because they don't have transportation and Medicaid actually pays for it. So there's all that. Um, so yeah, no, but we grew substantially. And I was going to make a comment. If you go on YouTube and you put in your neighborhood healthcare center or YNHC, PBS did an interview about the clinic back in 2009, right at the crash. And it gives you lots of kind of neat little pearls about what we did and how we did it and all that sort of thing that we may not get accomplished today.
So kind of went out there on a shoestring and did things, and it worked out. It sounds like works out well. As I had mentioned to Jim, and hopefully most of you know, I'm a big advocate for PAs in leadership roles. I think that's an important step for us as a profession, and look forward to talking to you some more, Jim. So thanks for coming on today.
Well, thank you, Sam. It was my pleasure.
Please follow the Physician Assistants in Orthopedic Surgery on social media. Please subscribe to our podcast. If this has been helpful, please take a moment to leave a review.